And now it is my pleasure to introduce our plenary speaker, Dr. Adnan Alseidi. Dr. Alseidi got into medicine over a bet with his dad and after a teaching opportunity given to him by a high school math teacher. He has exemplified a true growth mindset, traveling the world to study from other surgeons, learning how they achieve expertise and applying it both to their teaching practice and in their service of patients. Dr. Alseidi served as a surgeon in the U.S. Navy and as co-director of the surgery department at the U.S. Naval Hospital in Okinawa, Japan. He's directed surgical simulation training and hepatobiliary clinical fellowships, served as the Associate Director of the General Surgery Residency Program, and now as the Associate Dean for Assessment, Improvement, and Accreditation at UCSF. I met Dr. Alseidi earlier this year as a scholar in the Harvard Macy Systems Approach to Assessment program, where he generously shared his work on microassessment, with our focus this year in the TTR programs on assessment and feedback. I knew that the TTR educators and course directors would find his work inspiring. So please welcome Dr. Alseidi.
Thank you all, and thank you so much, Heather, for allowing me to be here. It's a true privilege, and I've always really been impressed with the work that happens in the transition to residency courses, and I realize how much effort goes into them. And I'm really honored to be here, and I also want to emphasize that I am always at awe on how much you all pack into those courses. So hopefully you'll find this whole useful. There's I'm gonna, this is just my disclosure since this is a CME event, but none of this is related to the talk. Transitions are really, really, really difficult. We've basically pretty much have been dealing with transitions in medicine by ignoring them, which is not a good way to deal with them, obviously. And really, the only transition that you see in front of you here that it's actually have had some effort, a significant effort, and actually, coordinated effort to actually deal with it is the transition you all deal with, which is from medical school to residency. So congrats on that. The transitions within residency, from residency to fellowship, from fellowships to practice, remain a really big problem in healthcare. And I think we all can learn a lot from all that you do and focusing on these transitions, because we do see not only that there is an increase personal injury and burnout in these transitions, but we also see that there's even harm to patients, especially when it comes to fellowship to early practice. So I think something that we all should focus on and work on. I'll admit that I had a little bit of a challenge thinking about what to talk about today, because again, I'm a little bit intimidated from all that you do, but at the same time, I do feel like there's a lot for us to learn from each other. So I'm going to beg your forgiveness in the beginning, because I'm going to put in a little bit of theory at the beginning. We're going to talk a little bit about what's changing in assessment. I'm going to talk about the concept of trust and how trust actually plays significantly into assessment. And it's probably one of the harder things to grasp. And then after that, I'll talk a little bit about our experience in surgery. I've been involved now for the last 9 years in what's called a key features examination, which I'll explain what that means for interns within the first 3 weeks of their residency, trying to assess where they are and how they make mistakes. And I feel like that results of those 8 years of data, which I'll show you, would be very insightful to what you all do. And hopefully maybe you'll find some things in it that you actually can use to actually alter your curriculum. But I'll also then talk a little bit about the micro assessment that Heather talked about and the workplace assessments that we're doing, which I feel like it's not only a very, very feasible thing to do now with technology, but it's also cheap. In fact, it's almost free. And it gives you an insight into the learner way beyond any other type of assessment. So, while everything in the world is getting more expensive and more complicated, I feel that now with web-based and app-based and AI technology, which a lot of it is public domain, is actually some things are getting cheaper, and this is getting cheaper and easier to do. So hopefully you'll find that fascinating. This emoji is only to remind me that I'm going to do a quick assessment in a couple slides. So please have your iPhones ready. We'll just do a quick poll thing so I can actually learn a little bit about you all as well. So that we can make this a little bit more targeted to who you are. Again, it's all about, are our interns ready? And I asked the AI to give me a couple pictures that resemble that, and it spit out these two images. And it really kind of reminds me that we not only don't know how, we know a little bit about how interns work and how residents enter practice during the daytime, but imagine at night when they're by themselves. There's a lot that we don't capture. So keep that in mind as we're doing all of this. So with that, just a quick assessment tool, if I could. I'm hoping that you're seeing my poll. And you could do this by QR code. It used to be that nobody knows QR codes, but now we all do. But also you can even text my last name to 2233, or you can go to poll/Alseidi, as you can see there. And I'd love to, the first one always takes a little bit of time. Maybe give me a word or two on what specialty you're in. And I think this may be educational for all of us to see who we are and what we do. And then I have 4 questions to try to see where we are with this whole process. And I think that will help me and help everyone to kind of see where we are. There we go. I've never seen such a rheumatology written in such big words before. That's pretty cool. Yeah, there you go, medicine. Yep. Wow, that's like every specialty. I love it. Very cool. Okay. I love seeing a lot of coordinators here as well. That's very helpful. Well, I appreciate everyone doing this. We have a ton of people. I like it. Okay. Very helpful. Thank you so much. So I'm going to move on to the question. This gives me a really good flavor of who we're talking to. So let's do the first question, which is, how well do you feel like you understand your learners entering your course? In other words, how well do you know that, their strengths, their weaknesses? Okay. I love to see that a lot of people do the assessments themselves. It's really good. I see. So about half either have some kind of knowledge about the students or they do their assessment themselves, and then the other half really know very little about their learners, which certainly makes it more challenging. So I appreciate that feedback. I think obviously this is something that we can work on. The second question is to what extent do you explicitly teach or assess clinical judgment? Things like prioritization, management of uncertainty. And there's a reason, obviously, for these questions, and you'll see a little bit about that when we show you the data from the national data. Love it. It seems like maybe 2/3 are actually looking at this, which is fantastic. As you can imagine, this is something that we actually did find to be a big deficit, but I'll show you, I'll give you more details about that. So that's about 2/3 look at that, I would say, okay? Very helpful. I appreciate you guys all participating in this. We'll go to the next one. How confident are you that your learners finish your course understanding the behaviors and attitudes that helps them build trust with faculty and clinical teams? Yeah, good. And again, as you can imagine, this is something that we found to be significantly a challenge with respect to entering internships, where they may know the knowledge, but they really have challenging understanding what behaviors and what's adult learning behaviors actually allow them to be more of a team, allow them to enter the team easier. But this is good. This is good. Okay. Last question. To what extent do your learners finish your courses understanding what they, because again, it's all a formative course, what they need to do to grow, okay? What they need to focus on. Even better, what they need to talk to their PD about, maybe things that they need to focus on. Okay. Spectrum for sure. Okay, very good. Excellent. Well, I appreciate everyone's insight into that. So I'm going to go back to this And I want to kind of just still briefly kind of discuss what, get us grounded all in the same terminology. This is a diagram that I use to kind of help us understand, where the word assessment plays out, and where are we when we talk about assessment, because it's not all, the words sometimes are used interchangeably, but they're not all the same. As you know, during medical school, we start with our residents, being in the novice phase. And the idea here is that we're trying to get them to advanced, and then we're trying to get them to competent. And you're seeing them after, really at the end of their medical school. And the question really always becomes is like, if they're competent, but also more importantly, how do people learn? And I want to focus on this really quickly. And I realize I'm talking to educators, but it's important that we realize that there are three pillars of learning. The first pillar is interactive teaching. The second is adult active learning, which we'll talk about in a second. But the important thing to understand is formative assessment, meaning that when we find a deficit in people, how are we actually allowing them to understand that problem so that they can learn? And this is the issue. This is like the whole idea of assessment for learning, is a lot of times we focus on assessment of learning, and we really don't really give feedback in a structured way that people can actually work on and actually improve, which is basically assessment for learning and assessment as learning. So I'll focus on this during our talk. Really, it's not about assessing if they're competent, it's assessment so that they can learn. The other thing that is very important in transitions is actually focusing on the learner's characteristics. And this is an important aspect, especially when it comes to transitions from a different phase in life. So for example, going from fellowship to residency to fellowship is not really a big change, but going from fellowship to practice is a huge change. Same as going from being a student, a medical student, to a practicing intern. That's a huge change. And these characteristics of understanding the importance of humility, reliability, consistency, communication, but also the idea that actually admitting that you don't know is actually appreciated. It sounds trivial, but it's actually comes down to a situation where we see it as a deficit much more often than we think. And the whole idea behind this is the idea of how do we develop trust? And trust doesn't come simply from ability, from knowledge or ability to do something. It really comes from a combination of integrity, benevolence, and ability. And this concept of actually giving this type of feedback doesn't come from the types of assessments that we typically use. And this is what Heather was mentioning in the idea of doing these micro assessments, that it gives people a more holistic approach of assessment of where they are, but also gives them that where is my deficit so that we can improve. The whole point behind this is that this is all still assessment for learning so that we can achieve competence. But this is also true when you're doing courses like the transition to residency. On the flip side, a lot of this data can be used to say, is somebody competent? And that's actually a very different question than actually assessment for learning. This is more to say, have really reached the competence level to where we want them to arrive. And I really want to focus on the point that we look at things from knowledge, from skills, from attitudes, and most tasks that we use have all three in them. The challenge here in medicine is that there is no assessment tool that assesses all three. The closest thing that we have is micro assessments and work-based assessments, because they do pull from attitudes and knowledge, but they still mostly focus on the ability to do something, to take care of a septic patient, to do a procedure, things like that. And this is why we really focus on these types of assessments, because we feel like it gives us the ability to actually not only say, is somebody competent or not, but also at the same time, it allows us to say, to give feedback to the individual in a way that actually is more holistic and allows them to grow faster. So I'm gonna go back to my PowerPoint here real quick and just say that the way we are trying to do in assessment is we're trying to move away from assessment of learning, and basically to say we want to focus on assessment for learning, which is basically to say a dialogue where we actually give feedback to individual. This is basically formative feedback, but also assessment as learning. And what this means is that we're giving a structured tools for the individuals to basically take an assessment, not to be graded, but to also be able to get reflexive, to give feedback in a structured way that is not pure self-reflection. Self-reflection is good, but not but self-reflection that doesn't have any guardrails can actually be can deviate towards a situation where they don't really know whether they're reflecting correctly or not. So structured assessment as learning and assessment for learning is really where we're basically gravitating towards. And this combines two things, which is programmatic assessment, which is assessment of data over a long time, and holistic assessment, meaning not looking at a specific domain, but looking at all multiple domains altogether. This altogether allows us to basically start talking about trust, which is a very important part when it comes to like practice, because it's really not just about ability, it's about putting everything together. And this is my last slide in terms of the theory, because I really, hopefully this is helpful to kind of show you why we're doing what we're doing. And the idea here is that what we're trying to do is getting the intern to basically be entrusted appropriately. But trust is not a function of the intern alone. It's a function of how complex the patient is. It's a function of the environment, the circumstances, which is really kind of what we call the system issues. And then also a function of how comfortable the faculty is in entrustment. And so all of these together say that not everything is about what you do in a course or teach the intern, but it's about designing the system for allowing entrustment. But in the end, if we can get the intern to actually adhere to the principles of benevolence, of knowledge and ability, we really do take a huge leap towards entrustment. So with that in mind, I want to kind of, there's two more parts to the talk. The first is I'm going to talk about the data that we've collected over now 8 to 9 years, which I hope that you will find to be very helpful. And then after that, we'll talk a little bit about what we're doing to kind of assess our residents in a holistic manner. This exam is called Entering Resident Readiness Assessment. And it's literally basically an exam that is given in the first 3 weeks. This is a formative assessment tool. However, what's unique about it is that it's focusing on what's called key features exam. And it's really the only key features exam in the United States. There is key features examinations that are done in Europe and also in Canada, but key features exams are not typical. And what it means, even though it's a written exam, it actually is not about does somebody know how to do something or not. It really is designed to basically say, does this individual taking this exam actually know, can perform something at a level of judgment? So it's basically working backwards. So we did a significant needs assessment to basically say, where do interns make mistakes? Where do complications happen? And based on that, we created vignettes to go backwards, cases that are basically focusing on those key features. So it's kind of a reverse engineered that way. And so the idea here is that it's a 40 short cases examination that gives them a patient, and they have to write. It's a write-in exam. So as you can imagine, it's not easy to kind of grade, but now with AI, it's a little bit easier. Each vignette has 2 or 3 questions. Once they answer a question, they go to the next one, and they build on that question, but they can't go back. And then the resident and the program director get a formative assessment. Again, this is given in the first 3 weeks of July, so it's very early in their residency. So here's an example, for example, excuse me, where basically the intern is given an exam to basically say you're called by a surgical ward nurse to see a patient who's become disoriented and combative in the past hour, and the patient has had a total hysterectomy 3 days ago. And this is basically designed to be in a way to actually, again, focus on things that we know are common mistakes that happen earlier on in the year. And they have to write things in. They can't, there's no queuing at all. There's no multiple choice test or anything like that. And so after they finish this question, then it goes to the second part, and the second part is gives them a list, and they have to choose what are they going to do next. And keep in mind here is that we allow them to choose up to 6. However, it's not all about the knowledge. It's all about, like, for example, are you going to call a resident or an attending? So we're assessing their understanding of the prioritization, but also their understanding of like the severity of the situation. And this exam, we've had significant enrollment. This is in 2025 alone. We had 807 residents take this exam, but we've usually had between 400 to to 800 over the many years. And as you could see, the statistics are incredibly tight and actually very predictive. And we've every year, we actually modify the exam to make it stronger, stronger. But it has become incredibly reliable, and we're able to actually give really good prediction of where the intern is and how capable are they of going into what we call indirect supervision. So here is an example. This is kind of the grading. We want people to be closer to 0.7. And as you can see, the different topics where they lie, and it's actually very tight confidence intervals. But what's interesting is that almost year after year, we see things like glucose control, respiratory workup of respiratory change, abdominal pain being on the lower end, or cold leg. As you can imagine, this is a serious situation where people are not able to confidently understand the prioritization. And because again, it's not about knowledge, it's about judgment and what they would do and not do. And so this is the most important slide. So what did we find besides the knowledge issue? What did we find to be actually common errors that exist that are errors of judgment in incoming interns? The first thing is there are 4 categories. The first category is not knowing what they don't know. So the lack of broad differential, anchoring bias, misinterpretation of data, where they basically narrow in way, way too quickly. This obviously has a knowledge component to it, but there's also an understanding. It's also a technique of understanding that that when you're looking at a patient, step back and look at the big picture. The second thing, which was actually quite troubling, is the misprioritization, where medical students still interns still kind of think like medical students, where they want to know what's wrong with the patient. Well, sometimes you have to treat a patient before you know what's wrong with the patient. If somebody is septic, you may not know where they're septic from, but you don't wait until you have a diagnosis to start treating them. And that was very pronounced actually as an issue. The same thing of like starting antibiotics before cultures, like that seems like almost counter to what we teach them in medical school, where you really want to just you want to really get a diagnosis before you treat. So they would do, and in other words, they would start antibiotics before cultures, or even they would get a CT scan on an unstable patient because they really want to know why this patient is they have a suspicion they're bleeding or something, and they really want to know that, but they don't understand that stabilization is actually the key factor here. The other thing is what we call reflective and communication issues, where, for example, they have a reluctance to ask for help. And this is a culture problem, or overconfidence, where they're really again, going down one rabbit hole very quickly. But the idea of asking for help was routinely seen as a deficit. And then contextual errors, where, for example, they make a decision on something and they start that treatment, but they don't reassess. And so, like, for example, they decide somebody has a pneumonia and they start the antibiotics and whatever it is they want to treat, and then they don't reassess, or they put in, or they even say this person needs a chest tube, and then they don't reassess, and the same thing, and that happened over and over again. So ignoring and not understanding the importance of trends as opposed to a one-time thing. So these issues cannot be assessed with a multiple choice exam. They cannot be assessed with a simple assessment tool. And for that reason, and many of these are life and limb situations. And again, we're not covering the issue of system. We're really looking at the individual alone. And I understand, as we said earlier on, that trust is not just about the intern. But if we look at the intern and say, what is the deficits? How can we give them feedback on this? You realize very quickly that you are really dealing with adult learner qualities that you cannot assess with normal assessment tools. And this brings us to the whole idea of using micro assessments that Heather mentioned in work-based assessments, to basically say, we want to be able to actually give them more holistic assessments. And this is a lot of the work of our surgical education fellows and Dr. Vu, who's one of our pediatric surgeons here. And so what this means is basically we're looking at work-based assessments to basically say, how can we actually assess them? Now, you could do this for a cognitive thing, like treating a patient with sepsis, or you can do this for a procedural thing, like I'm going to show you here as an example. Before we go too far into what we're doing, I want to just point out that we're not even using an app. We're literally using Smart Sheets, which basically is a very simple, like Qualtrics kind of like type survey. And we have it done as a web. And then we basically give people this instruction where they take the website and then they click on this on their iPhone, and then they save it in their home screen. And all of a sudden, you have a poor person's app, which is basically a web-based app that actually is on the iPhone. And I'll just show you an example. This is my phone. I clicked on that app. Just go back there. That's the app there. I click on it. Even though it's not an app, it's a website. I choose which work-based assessment I want to assess. In this case, I'm doing a nested work-based, and I'll explain what that means in a second. I'm going to click on that. I'm going to fill out the resident's name, fill out my name. Because it's not an app, it doesn't auto-populate, fill out the date. And then there's basically 4 or 5 questions. And in the end, it asks me what level of entrustment this individual is at. And as you can see here, I'm going to put them as indirect supervision. And then I basically dictate. In this case, I was typing. So I'm going to just say dictate. And I just dictate like a paragraph or two. And then I just send it. And the whole thing took, let me see here. This one was like 36 seconds. And as you can see, with the 36 seconds, we actually can collect a lot of data points on each individual, and I'll show you that in a second. But more importantly, I don't want it to be a big thing. I don't want it to be a situation where we're only assessing people on like a big procedure or a big holistically taking care of somebody in sepsis from A to Z. I want to focus on very specific things so that they are actually digestible pieces. So for procedures, what we did is we took all the common procedures and we said which modules are actually exist within each of these procedures. So we have things like opening an abdomen. Even though opening an abdomen is not a procedure, nobody comes into the hospital to say, I'm coming here to get my abdomen open. But we basically say, we want an intern to be entrusted in opening an abdomen or closing an abdomen. So we're looking at very small specific procedures. And you could do this also for patient care in the ward. Like you could say, I want to know if a medical student can take vitals or whichever. So in essence, you could do what's called nested, where these are nested in these big procedures. So again, you can create as small pockets as you want. And then the whole idea of nesting is it allows you to assess early career people at an earlier stage. So for example, in surgery, we could say, okay, we have 2 trainees. One is an intern, one is a PGY5, and the procedure is an XLAP for small bowel obstruction. The PGY1 is being assessed on a nested EPA, which is a nested microassessment, which is abdominal entry and closure, while the senior is assessed on something else, and then goes on and on. That way, you can actually get data that is actually applicable to that level of that resident. And again, this is not just about procedures. You could do this on the floor as well. And this is the data you get. You can actually get a ton of data points that actually allows you to basically say, this is just basically looking at one resident over time. And you can look at it from a concept. This is, again, residents. You can compare, sorry, this is services, which how many, and you can see which service is actually doing more EPAs, but you can actually look at this in terms of residents, and you can see the people who are senior are getting have a little bit more data points. But then more importantly, after that, you can also look at faculty and say which faculties are doing better, and you can give faculty feedback that way as well. But more importantly is that you have these dashboards where now you can actually see where are they being entrusted or not entrusted. And the question here is then you can take all this verbal dictations, which sounds like a lot of work. And actually now with LLMs, we can actually put them in our local chat GPT is called Versa. We put them in Versa and we actually get a very rich thematic analysis that actually gives that intern feedback on why they are not being entrusted or how well they're being entrusted. But more importantly, it's not just words, it's actually, sorry, it's not just ratings, it's actually very, very robust feedback that actually looks at them holistically. So I have a couple more slides, and then I'm hopeful that we can have a robust discussion, and I'm looking forward to learning from you all. Obviously, doing something like this takes a village, takes a lot of people to kind of buy in. It doesn't require a lot of IT work, and it does not require really any money. We didn't pay anything for this because we already have a institutional subscription to Smartsheets, which is similar to Qualtrics. But to get the word out, we did a grand rounds. We had these champions that actually get people motivated, but we also had residents look at their dashboard and actually compare themselves to other residents, which I think they like. At the same time, we also had residents actually help attendings get this thing on their iPhone. Sometimes attendings require some help for some IT stuff, but once it's on the iPhone, it becomes really easy. And again, we still have other plans in the future to actually be able to integrate this even more smoother. And now there's actually even more apps that are actually free. Like there's one that that we're working with right now called Firefly Labs, which is out of Portland, that is actually free to use, and we're looking to partner up with them, which would make this even easier than what we have right now. So with that, I just want to have one more slide, which is my summary sheet. I just want to kind of point out a few things, which hopefully will be helpful to all to see, which is that really there's a shift from like this episodic, away from episodic assessment of learning to programmatic assessment, a lot of data points, and even integrated assessment. And what integrated assessment means is that we basically say there's no more test at the end. So we look at a lot of data points, and all of them are formative, and all of them together are summative. And so the way you do it is you basically remove the outliers, and then you basically take them together and say that's where the trend of that individual is where they're going. And the good thing about this is that it not only allows you to assess knowledge, but also allows you to assess judgment and trust in a much more holistic manner. Remember that judgment errors remain a significant problem in transitions, even transitions from medical school to residency. And these things do fall into interesting categories. And you all know this probably very well, but this idea of misprioritization, we saw that in the poll we took earlier on, more than half people focus on that, which is wonderful. The contextual errors, meaning that just because you did an intervention doesn't mean it worked. You have to reassess. That's an important thing for people to learn. Not knowing what when you don't know, again, a really important thing to actually say, okay, maybe for the first few weeks you should be calling for help more than often, and actually giving them permission to call for help. And I know some interns are really good at that, but others are very skittish about it, which again, it results in harm. And then learners embracing discomfort, like the idea of giving feedback on person's benevolence, person's integrity, person's communication skills is much harder than saying you didn't know this or you knew this. But it's something that's important. And I think creating that work environment that allows people to be comfortable in actually embracing discomfort is a huge thing. And maybe the first step in that process is actually saying that discomfort is not bad. In fact, that's how you actually learn. And then lastly, this work-based assessments, micro assessments, I think it's really, as I said earlier on, while everything seems to be getting harder and more expensive, this is probably the one thing that has actually gotten a lot better and easier for us to do. So I'm excited about doing this more and more, and we're creating more micro assessments every day, and hopefully we get to share some as well. So with that, I'll stop, and I look forward to any questions and or comments, and looking forward to learning from you all. Thank you so much for inviting me again.
Thank you so much for such a great talk. I have lots of questions, but I'm going to hold my questions until later and point you towards a couple that came in the chat. One of the first ones was that you mentioned that your findings were very predictive of future intern performance. Can you talk a little bit more about what you correlated with that and what it's predictive of?
Oh, yeah, in the national examination, it's when we look at these results, we then actually ask program directors to look at how interns are doing in their milestones over the year, and actually the findings were predictive of like which ones will fall behind the milestones. That's what I meant to say.
And do you see, like, are there program directors then using that prophylactically?
Oh, for sure.
Coaching or mentoring?
Absolutely. In fact, when there is one of the biggest questions is like, how do you decide what do you teach in the didactics, or what did you teach in your interns in the first few months? And this becomes a very good tool to say, well, this is where my deficits are. That's what I'm going to work on. But also to make it, as in the age of precision education, to basically say, let's look at each intern individually. They all get their, for lack of a better word, report card, and to basically say, okay, take that, and actually now, instead of like studying based on, going from the beginning of the book to the end of the book, focus on where your deficits are first, which makes more sense.
Great. Jamie mentioned the Simple pilot project that's going on in pediatrics, but Simple actually started in the surgical world as well. Are you familiar with that, and how do you see that fitting in with the work that you've done?
So I love that question. And as you said, Simple, just for everyone that's not in surgery and pediatrics, is an app. It's an app that does micro assessments. It's nothing too special. And part of the challenge is what I don't like about Simple is that it's basically one size fits all. And as I was trying to show earlier on, part of my challenge is that if I was to use simple, what I have to do is I have to focus. Let me just show you on this slide right here again. If I was to use simple, I have to focus on these big procedures, which is fine for the senior residents. However, it's not fine for the juniors, because they're still not going to get a lot of feedback, because they're not doing pancreas resections, they're not doing colon resections. And so by doing this on our own, we can actually literally design work-based assessments on small nested things that we find to be troublesome, right? So for example, a simple thing like I'm not a trauma surgeon, but like in trauma, we find that sometimes there's an increase in missed injuries, like non-vital missed injuries, like a broken finger or something like that. Well, you can have a nested EPA on like a tertiary exam. That's not going to be in simple, because simple is focusing on big EPAs or big micro assessments that are really kind of like competency for graduation. So doing this on a local basis allows us to create ones that are troublesome for us, as opposed to following the trend of the national trend.
And I might have missed this before. With what you've done, have you included how complicated or like kind of the complexity of the
Yes.
pieces?
Yeah. So the way we think of it, it's basically the answer is yes, but on a case by case. So, for example, if I'm saying going into an abdomen as a nested EPA, but this is a redo abdomen, we ask the question: is it simple or straight complex? Is it moderate? The difficulty of the case, is it simple, moderate, or complex? However, if I'm saying assessing a cold leg, we don't ask that question, because a cold leg is a cold leg is a cold leg. We want to know that you are, if you're a PGY2 and you're called to the ER because somebody has a cold leg, we want to know that you are interested in that holistically. It doesn't matter if it's complex or not at that point.
Great.
I mean, it's all complex, I guess, for a cold leg. So, so.
Emily had a question about the dashboards that were created from your smart sheets. So you had,
Yeah.
like, what did you use to create those?
It actually, this is the beautiful thing about things like Qualtrics and Smartsheets. They will spit these out for you automatically. There's nothing to create. I suspect most universities have institutional licenses for many of these survey-based kind of softwares, whether it's, I think there's like so many now. There's one called Smart Survey Gizmo, there's Survey Monkey, there's Qualtrics, there's Smartsheets, and it doesn't really matter. You can create this in any of them, and then it will spit out those Smartsheets for you automatically.
Great.
I see there's some comments there. People have used Qualtrics. Yeah, I mean, honestly, we started off with Qualtrics, then we moved to Smartsheets, but have you also used Survey Gizmo? There's just so many out there, you know. Whatever the university is paying for, I guess, is what I would use.
Yeah, that's a good approach. There was a comment from Elise, and then Emily commented on too, talking about that, especially in the UME setting, rank list submission, that students get really can take formative feedback and then very much interpret it as summative. And obviously, you've used this more in the residency side, which I think has a little bit less of that pressure. But have you seen, have you done anything in the UME space or
It's a
had any
wonderful
issues with that?
question. It's a wonderful question, and it's a difficult question, because it's all about the trust that you have. I hid this slide just to stay on task here, but the traditional approach is we have this, maybe some feedback in the middle, and then we have this test. And the pragmatic is that you want to actually have a lot of assessment for learning, and then you still have a test. But where we really want to go to is where we have a combination of assessment for learning and assessment as learning all the way through, and then no summative test, because we know that the best way to do this is to actually take all this data and remove the outliers, and then all of this becomes your summative exam. Basically, in other words, you're looking at this data over the whole 4 weeks, 8 weeks, and saying, based on this, by removing the outliers, I can see the trends, and I can see whether this person is achieved the objectives of this rotation or not. The bad part about this is exactly the question that you just read, Matt, is the fact that now that psychological safety that this is formative and is not grading you, if you will, is gone. And so this is where it's a tricky, because you have to reassure people that a bad day, having a bad point here, doesn't actually hurt you, but it does have that issue where everything is formative and everything is summative, and that's still something that we need to get learners over.
Yeah, and Heather actually had a good point that, or question that goes with that of thinking about how do your CCCs review data in, by obviously they're mandated to do it every 6 months.
Yeah.
But how do you think about the appropriate volume of micro assessments if you're having these like summative discussions?
Yeah, it's a wonderful question. So the way we look at it is in terms of whether we're looking at the CCC or whether we're looking at the CAP, which is our Committee on Academic Progress, and is what we want to have a lot of data points. And so what we do is, if somebody doesn't have enough data points, we sometimes push them a couple of months later on and actually see what's going on and why they don't have enough data points. Because in the end, we don't want the CCC to meet and just say, well, they must be okay because they're doing okay. We haven't heard anything about them, but we're guessing, right? So to answer your question, is that we do this every 6 months. However, that doesn't mean that we can't do it every 3 months until we get data. So if somebody is not getting a lot of micro assessments, that is in ourselves, like, I don't want to say a red flag, but that's like a yellow flag. And then them and their coach, their mentor, will actually know, like, hey, you need to start getting more data, and will be rediscussed in 3 months. That's how we do it.
How do you guys think about what's not enough data?
Oh, it's a good question. So it's statistically you can actually measure that, but to us is, at this point, we're aiming for anywhere from 20 to 30 data points per month. We feel like that becomes a situation where you have the noise, you have the 4, 5, 6 outliers, but then you can start seeing trends. But if you're not seeing trends, that's a situation where you're like, that's either not enough data or there's something else going on.
Great. One, Olivia, had a question about how did you deal with the privacy concerns with LLMs as you're giving data
It's a
to it?
great question. We're lucky. So there's 2 ways to deal with it. The way we used to do it in the past is that what we put in there is we basically gave every single learner a code name. And the good thing is with ChatGPT is that it actually can save that file in a code name in a person, and it's really literally piling up that data on a code name that's not a person. However, since the last couple of years, we've been lucky enough that we actually have an internal LLM, which is actually restricted within UCSF. So now we just use that, and for that one, we don't have to worry about it because we can put FERPA stuff in there too.
Jeannie had a question about how quickly do your learners get the feedback that's submitted by their assessor?
Literally, so when I was doing over the weekend, when I was doing this, they've kind of gotten obsessed with this feedback. But nevertheless, when I was doing this video for this, because I figured I'd do a video, so I made this video over the weekend, and I wasn't intending to click send. So I literally clicked send at the end by mistake because I'm so used to it. And then literally I got a text from that resident like, you just sent me a feedback. We haven't worked together in the last month. And I'm like, oh, so they get it like literally within seconds. But yeah, I actually had to email our coordinator to remove that one because obviously now it's in his file and it shouldn't be. So yeah.
Do you see that causes problems where they're wanting to discuss feedback more rapidly, or that they get upset by something that was put in there?
I mean, I think it's a wonderful question. And I think if you have that form of trust, they realize that none of this is meant to be pass or fail or anything like that. It's all about feedback. So yes, it does stir more conversation, but I feel like that's a good thing as long as people are talking and having that dialogue. But yes, it does, like some residents will feel like, like they want to talk about it, but I don't see that necessarily as a bad thing. And hopefully there's that good environment that people are actually willing to have a conversation.
Great. Elise had another question about feeding forward, and I actually would expand this to ask you the question of both directions. And so Like, have you looked at feeding forward data across any of the transitions or backwards?
So I love that question. This is where a real app is better than what we're doing. What we're doing is easy and free and completely malleable. But for a resident, like when I have a resident enter my OR or my rotation, they can actually show me their data of where they are. In other words, like what level of entrustment they've achieved in a certain thing, which is really helpful for me, because then I'm seeing what my peers have actually given that feedback, and I can actually then appropriately take them from that step to the next step. So you'll have a second year that says, I'm interested in doing this so-and-so, which is wonderful, because it allows me to actually then just build on that and not necessarily wait for 3-4 weeks of watching them taking care of a patient before I allow them to do it independently. The app allows it even better, because then literally I don't have to, they don't have to show me. I can literally look at it, a week before the transition of residents or medical students. I can literally just look at it on the app like Firefly and Simple and see what kind of feedback this person has been getting. And to me, that just makes this feedback a little bit less of a high stakes situation where they know, I know what feedback they've been getting. And also, one of the things that we've been doing is trying to make sure that we give the learner the benefit of the doubt, meaning this idea of removing outliers is actually very essential, because we all have bad days, right? And so if we can remove outliers and kind of look, instead of looking at each assessment, the faculty don't need to look at each assessment. They want to know what the trends are. So the trends are important. And to me, the trends are actually where it's also more fair as well.
So have you all looked at feeding things backwards? It seems like you have a bunch of data that might be helpful for transition to residency courses in particular. And if you haven't, what would be the things that you would select for your surgical interns? Like if TTR courses could fix something before they
Yeah.
showed up to see you, what would you pick?
No, it's a wonderful question. We've been feeding this mostly internally to our didactics on our courses, but not necessarily backwards to the TTR courses. But I think where the power of the TTR courses, like you're absolutely right. There needs to be a feedback to these courses to actually help. And now that there's national data through Simple and Firefly, that's something that we absolutely should do. I think where I still find the issues are still the issues of like trusting the fact that, the four big categories that I showed, which is the idea of like of knowing that asking for help is expected. It sounds common sense, but it's not common sense to a lot of people entering. The idea of prioritization, the idea of like it's not your job to solve this completely solve this patient's problem. It's your job to stabilize them and start the process and communicate. That idea is not necessarily entrusted, is not internalized, and I feel like that's where a lot of the work can happen, to basically say that you may not actually, your job may actually be to literally just make sure the patient is safe, get the process going, and communicate. And a lot of times people look at that, or interns look at that, and I feel like I'm letting the team down, which is absolutely not the case. So that kind of knowledge is not something that we typically teach in medical school. So, that may be an important thing in transition.
Yeah, I would speak from the transition to residency side and say that these are the things that we are generally prioritizing. But we're always looking for ways to pinpoint what we're doing and really target making, our graduates even more ready for whatever they're going into. And
That's
so
awesome.
I think that's a step that we can all take too, is to try to start soliciting this data nationally and bringing it back to
Yeah.
us and say, hey, here are the problems that, people have uncovered that we should try to see if we can adjust
Yeah.
our teaching for. There's a question about organizational change. So you talked a little bit about getting people to get the app downloaded and to use it, and you're talking about, in essence, one micro assessment per day per resident as your target goal. How did you convince everyone to do this work? And, did you see pushback about adding another burden on top of all of their other responsibilities?
It's amazing. Like, you have to give people a break, and so it's amazing how you can't add without removing. I find this not only to be more reliable and more valid than this long form, we call it the MedHub long form that everybody hates. This is so much easier to do, and it's actually fun for people to do. And so the idea here is to find something that you're doing in flow. And so the comment of basically saying, okay, have one of the residents literally take a faculty through it. So as they're literally walking out of the OR to go talk to a patient, in that time, they can't do anything in the MedHub. They can't do any long form, but they can absolutely do one, if not two of these. And especially because I'm not even asking them to type, I'm asking them to dictate. And so, it's first, it always sounds like a big deal, but then the key is to have people do it. And I could show you, like, I blanked out the names, but the highest people who are actually putting in the micro assessments are actually the busiest faculty, which sounds kind of counterintuitive, but the reason why is because unlike all the other assessments that we do, this is completely in flow. This is like, it doesn't really require them to sign in, to be on a computer, to sit down, to do anything. So I think it's kind of making sure that people understand that. I feel like the power of this is not only the type of feedback you get, but also it's like, it really works for busy faculty, I think.
Your residents are getting the feedback in real time, and a probably pretty constant flow. Do you have in your system advisors or coaches or people who help them interpret that as they go?
Yeah, so we do. However, what has worked best is that the CCC, for the residence part, the CCC, for the medical school part, they actually get it on their dashboard, and we're changing that a little bit better, so they see it immediately on a dashboard. However, for the residence part, the CCC combines all this data, but also combines all the case data and all the other assessments, everything, and then they get a letter with links um, uh, to them and it's actually a DocuSign, to them and to their mentor. And then them and their mentor have to sit down, go over it, and both sign it. The idea here is that they have access to all this data, comparing them to their class. Obviously, not the class. Their colleagues are de-identified, but the aggregate, I should say. And then they basically are seeing it. So twice a year at least, they're seeing it in mass, but then they're also getting the feedback individually all the time.
Do you think that in your residents who have maybe a lower amount of insight or a little less skilled with like personal driven growth, that this has been helpful or no different? Or do you think that this is something that they are, still
I,
able to kind of continue on the same track?
No, I really do believe that it's helped people gravitate towards the middle. And the reason why I believe that is because individuals that are getting all these data points are seeing how the feedback they're getting, and they're actually seeking help. And so things like, for example, we'll get some residents who actually will email and say, I'm struggling with this. Can I set up a time? We're lucky in the sense that we have 5 surgical education fellows. So can I set up a time with one of the surgical education fellows in the sim lab to work on this? Or can I, or they'll work on a specific cognitive deficit that they have. And so I do feel like it gives them the agency to actually help themselves. I mean, it's obviously not 100%, but at least it's so much better than this radio silence that happens. And then all of a sudden, at the end of the year, they get this, letter saying, well, people just don't trust you, but we're not exactly know why, which is not very helpful.
Okay, I've got one more question for you, and then I'll let you leave us with whatever pearls of wisdom you would like to send to us. And so the question is can you envision a way that you think micro assessments could be adapted into a transition to residency space in a way that would
Yeah.
be helpful in the transition or to residency programs?
I love that question. I mean, the way I would think about it is that, and this is why I asked those 5 questions at the beginning. As you said, Matt, you all are already way ahead of the curve when it comes to transitions. Like before I moved to this position in UME, I was doing a lot of GME and a lot of faculty development, and the transitions between GME, so GME residency to fellowship and fellowship to practice, are really, really, really problematic. Like not even close to where you all are. So you're already ahead of the curve. However, one of the things that you noticed in my question is like, how much information do you actually know about your learner going in? And more than half said that they don't know much information at all. And so the question is like, why can't a group like yourselves have these macro assessments and basically say, you're going to have this course in March and April. We want you to have 60 data points between January and March, as you're going through. And actually, you can even have a situation where they have a QR code where whoever faculty they're working with, doesn't matter what topic they're in, they can scan the QR code and give a micro assessment. And that data then feeds into your program director running the course, the TTR course, which I feel like would actually be really towards the precision medicine in the sense that it will allow some more direct, personally directed information. But other than that, honestly, you're all already focusing, as you said earlier on, Matt, on what's important. It's not about knowledge. I mean, knowledge is important, but knowledge is so easy to get these days. It's about cognition. It's about judgment. It's about, humility. It's about communication, and that's where the errors happen.
Great. Okay. Do you have any last pearls to leave us with?
No, thank you so much for inviting me, and it's been incredibly educational for me. As you noted, you all really are doing an incredible amount of work to not only get the learners more comfortable, but to also get the program directors more comfortable, and more importantly, keeping that transition in a safe zone. So I appreciate all the hard work you're all doing. So.
Well,
thank you so much. Yeah, thank you, Dr. Alseidi, for your beautiful discussion. Thank you, TTR course educators, for your questions and engagement. It's